I'm self-taught, and my expertise is what I've developed only by doing. Starting 7 years ago. 7 years ago, my husband died for all the wrong reasons, 8 days after successful surgery in hospital. And that's not a part of what I'm going to talk about today, but of course it's the door that opened, and my mental model of what healthcare was didn't match at all with what I encountered. And as much as anything, it was the disservice done to the healthcare professionals who were devastated by this unexpected death. And I really dedicate all my work to improving the conditions in which people practice healthcare professionally, because I have this sort of underlying belief that if we create a happy environment for people who do choose healthcare as their way of making a way in the world, then patients will be better off than anything else I could possibly do. So I've been asked to talk about patient engagement leadership, and I'm really going to step back, and that's because I come from the real world into this world. Okay, thanks. And I guess I want to talk about culture. I want to talk about context in which we do our work. Later today, you're going to hear some fabulous examples of patient engagement, and I'm not going to do that in my time this morning. But I do want to talk about different levels of looking at the context for patient engagement. And if you like, if this is your background, on a macro level, it's about culture. On a meso level, it's about connection. And on the individual level, the micro level, it's about relationships of trust, reciprocal relationships of trust. And I think that that's fundamentally what healthcare is about. So in the beginning, for thousands and thousands of years, this is what medicine looked like, the practice of medicine. It was damage that we did to our bodies that we encountered. We got an expert to come in and repair our damage. And I'm not sure exactly when this painting was done, and it looks Dutch to me, but there's some interesting aspects of it. You know, it doesn't look very septic, or it looks rather septic. It looks like antiseptic procedures are really not a part of it, and we've got a cat on the floor. And out the door, well, on the door there's an owl, and I think there's a lot of symbolism here that I'm not sure I understand, but owls oftentimes were a reminder of death. And then out the door, I can't quite focus on it, but there may be a guy walking with a crutch as a reminder that the consequences in the Middle Ages were that this man may have a serious turn in his life, or his life may end rather rapidly. I also think it's interesting that there's an observer peering over the shoulder of the medical professional. So this is repair to return to function. Well, zip forward to this last century, there's been a revolution in the way medicine's practiced, and now you'll notice that the patient has all but disappeared. It's a procedure, it's a body part, and we have a team of experts who are highly trained, who are focused on halting the natural process of a disease, perhaps, so interrupting something that's underway. There were symptoms that led to a diagnosis, that led to a decision about what kind of intervention should take place. And oftentimes this is about prolonging life. Returning to function, yes, but prolonging life is a good deal of the way medicine has evolved in this century. Well, here's the future, and it's here now. And this is molecular medicine. It's the microbiome. It's looking at there isn't a patient there. There's an extract of a patient. There's a DNA sequence. And I think we're entering a world of medicine that is about predicting what will happen. It's not waiting for the symptom. It's looking at the likelihood of diseases or conditions arriving. And it's about avoiding adverse reactions before the adverse reaction happens. So targeting medication to patients based on what we can predict, what we can know. And as I say, there's not a lot of relationship here. So I wonder, and I think it's important for us to think about how the culture of medicine influences the relationships we have and the way in which we interact and will interact in healthcare. This is the outcome our medical model has been aiming for. We've prolonged life. And I think this is one of the huge challenges as we skyrocket along into the future. Is this really the goal? More and more people, I think, are talking about well-being. Now, I'm not going to analyze what's going on in this picture, but I can fantasize all kinds of aspects. There's a lot of best practice here. But there's also a lot of social isolation, it would appear. And I wonder what this patient would talk about in his anticipation ahead. I wonder what this person feels their life is full of. And where is well-being here? Have we talked about well-being at an earlier time upstream in this person's life? So our medical model oftentimes presents itself to patients this way. We're in a standardized process. We're on the assembly line. There is very little variation in practice, and that's best practice. And we're put through a patient pathway that someone else invented or that maybe we help participate in. But if we're the fourth hip repair on Wednesday afternoon, it's looking an awful lot like the fifth hip repair and the third hip repair. And it's not about relationship, it's about getting through a process. From a practitioner's standpoint, healthcare may look like this. And I would say that this is one of the huge risks that we run right now as, again, we standardize and we mechanize the delivery of healthcare services in order to get the numbers that we want. That it's what we can count becomes the priority, that is what we count, rather than asking what we might count. So this is, to me, a real formula for burnout. And when I look at the specialization and the isolation, the fragmentation of healthcare, I see the costs that imposes on practitioners as well as on patients. When there's an adverse event, the isolation can be devastating. And we all know way too frequently of practitioners who have left clinical practice because of those pressures, and people who, in fact, who have taken their own lives because of the pressures of simply continuing. Well, the British Medical Journal in May of 2013 had a most remarkable cover and editorial, and I'm going to read just a few words from it because patients are clearly not content in that same medical model. And I think this is part of what Angela was talking about as a whole simmering movement of patient empowerment. But this is from the voice of the editorial board of the British Medical Journal. The preservation of institutional bureaucracies, as well as professional and commercial vested interests, have consistently trumped the interests of patients. The healthcare industrial complex stands accused of losing its moral purpose. And this corruption in the mission of healthcare requires urgent correction. How better to do this than enlist the help of those whom the system is supposed to serve, the patients. Far more than clinicians, patients understand the realities of their conditions, the impact of disease, and its treatment on their lives, and how services could be better designed to help them. So let the patient revolution begin. And that was 2 years ago, and I think we're still actually just at the beginning of that revolution. Here are the words that are kicked around all the time about who that patient is. Who are we serving? Well, is it the consumer? That's a word that's used in Australia very frequently. Outpatient, inpatient. That's kind of within the system, but it's the way we identify classes of patients. There's the patient partner, and that's the language we're using today in this conference. The resident, depending on where you are, what modality of healthcare you happen to be in. What about communities, their whole populations in society who are dependent on the healthcare system for well-being and support? The layperson, the person coming in from the outside who has no expertise and training in the technical aspects of medicine or healthcare, but may have incredible, brilliant insights into the practice of healthcare. the user of systems, the user of services. So there's a huge variety of language, and in English we don't have good terminology. In other languages, I haven't found a label that really works, that encompasses all these roles. But all these words and many more are really what we're talking about when we talk about patient engagement and we talk about patient partnership. I use the phrase the citizen patient for very particular reasons, and it's personal in a way I think is embedded in Canadian society. And the way I like to define this is a person who may or may not have particular individual experiences in healthcare, but who wants to have an influence on the conduct of the healthcare system, who wants to look at redesign and reform of the healthcare system, for a variety of reasons, not least of which to have a system that really responds when they need it, when I need it. But it's an altruistic motivation. It's better health care for everyone, a system that's responsive for everyone, and in part because I'm a taxpayer, because I fund this system, and also as a citizen, I want to live in a society that has a healthcare system that functions at that level. So the citizen patient is a generalist who's looking at system-level reform, and that's the kind of work that I do, and I think it's necessary, and I'll try to talk about some of the ways that works. There's always a fear inside the system. You let a layperson in, and it's going to be complaints and harassment about how bad care is. Well, in fact, this isn't the experience, and I think most of the people in the room now have realized that when you invite outsiders into the system, the revelation that there's so much going on to improve the system already is stunning to the ordinary person on the street who doesn't know the inside of healthcare. The idea of patient safety, first of all, the shock, you mean patients aren't safe? And then to look at the investment of talent and budget and skills into creating a safer system is quite a surprise for many people. I think in many ways this slide is becoming old hat for us in patient engagement, that this fear is becoming less and less a barrier to patient engagement. But the other thing that I would say about this is that when we look in the lower left-hand corner of the two lineups, you know, the complaints and the gratitude window, what we're very poor at is having a suggestion box. When patients have had bad experiences, they actually don't want to continue the bad experience with confrontation and hostility. They want to make it better. And it's very clear in the evidence that's been collected all over the map that the best reward for a patient who has experienced bad care or a tragedy is to see that no other patient experiences that or no other family experiences that. So it's a very creative impulse. And I think when we engage patients, we oftentimes find that the first volunteers are the people who come from that experience background, who have that kind of experience. They absolutely want to give back to the system, and embracing that contribution and the insight and expertise is essential. It's essential not only for the system to learn, it's essential for the healing for those people who've experienced that poor care. Well, it's not as though the rest of society isn't talking about healthcare. Everyone has healthcare experiences or knows someone who has or is becoming concerned about what healthcare is for them. And we're not doing a very good job at this point in tapping into that wider discussion. There have been lots of studies recently in Canada about the need for an open dialogue and discussion about the future of healthcare for this country. And I think the more we do to engage patients within the system, the better the expertise is in the wider society. As I mentioned yesterday to a few people, in Denmark, notably, the Society for Patient Safety refers to its volunteers from the community as patient ambassadors. They see the information flowing the other way, back into society. When someone has a healthcare experience, you know that experience spreads through their family, spreads through their neighborhood, spreads through their social contact. I think if we think about the level of unawareness, of ignorance, if you like, in society, the more we engage patients, the greater the expertise is in society. The internet has facilitated that networking. Our care networks look something like this. When we're dealing with a patient in a clinical setting, The patient themselves has a context. They have a family, they have a background of relationships and attitudes, of education. They have many people who help them get to that clinical experience and many people who will support them when they're out. It's the pharmacist at the corner. It's my Aunt Dolly, who also had this procedure, who told me about what it would be like and that information relationship. It's my children who I'm going to tell about how my experience has worked out and give them lessons for their future. It's also about the healthcare complexity. Although it may look like a dyad of doctor-patient, everything that comes in from that clinical background of that physician is within the experience of the patient as well. So understanding that our care networks are incredibly complex when we map the patient journey, it's a reductionist approach to what's happening that's not at all what real life is about. So when we're engaging patients, we need to understand that they bring with them a suite of connections into the society that's far beyond what is there on the surface. It really is citizen-patient communities that we're engaging. And I think the more we think about the intergenerational and the complexity of those relationships, the better we are at imagining what we're actually building when we engage patients. Within the professional ranks, there are big changes going on. Angela referred to some of those changes in medical schools. This is at the University of British Columbia, where I'm very privileged to have a faculty position. Gives me insight into what training is and preparation is in the health professional world. This is teamwork. These are many voices being heard. This is flattening hierarchy. It's respecting the expertise of individuals and looking at collective wisdom and collective approaches and collective knowledge. Opening up the opportunity to be expressive about concerns and experience. I think everyone wants the same kind of model where hierarchies are flattened, where every voice has a place at the table, where information flows seamlessly. In order to make that happen, we have to invite all the players, and to be able to think about the complexity of those networks is essential to building this kind of model of patient engagement, either on an individual level or on a team level and a system level, for system engagement, for oversight, for governance, for research, for evaluation, for measurement. Recognizing the diversity is the key to the strength, that we are as strong as our diversity, and when we see that something is not quite fitting, we need to embrace it and bring it to the table. Not quite fitting means they have to be there. They are a part of the network. So no matter how you might slice diversity, embrace diversity as you build teams, because that is the strength in your performance. I love this cartoon of resilience. This is the kind of, at least that's what I impose on this drawing. So here are these diverse and agile and flexible network of people who are ensuring that the health plan works, that the health system works, and that the clinical delivery works. So as we look at how to cope with the expected and unexpected disruptions that are the reality in healthcare, it is resilience through that complexity, through those networks of collaboration that enable us to cope. When I look at the design of patient engagement, I'm always, an echo in my mind is enabling relationships. And in those relationships, we can address what Eric Hollnagel has identified as 4 dimensions of resilience. The ability of a system to respond to the stresses that get it close to the edge, to monitor, to be aware of how close are we to the edge. How can you know this without interacting with patients and the patient communities? Anticipating, being able to see the trajectories collectively, being able to understand when we get close to that edge of stress, and to learn when we do get to the edge or perhaps fall off the edge, to actually learn what has occurred and to benefit from that learning. We're all patients, Carolyn. I steal this line from a great patient leader, David Gilbert, in the UK. What, all patients? I can't represent, and I think I've very consciously avoided the word patient representative, the idea of a representative in patient engagement. How can anyone represent anyone but themselves? However, what I would say is that a patient can ask questions on behalf of many patients in their perception of what the patient world is. And asking those questions can be the catalyst to involving experience that's way beyond one's own. But there are a lot of other things that are in this cartoon that are important. And it's recognizing that every time we engage patients, we need to look at the screen that's preventing some kinds of people being there. So if we ask for people to come voluntarily, we may be excluding people who can't step away from a job or can't fund their own participation. When we ask people to come at 3 o'clock in the afternoon, who are we excluding? When we ask people to come on their own steam, to take public transit or to drive, who are we excluding? When we ask someone to come for 4 Thursdays in a row, who is not going to be a part of that team? So becoming aware of the way in which we recruit is a critical aspect of recognizing the diversity or the lack of diversity that we're building into our system. I spoke about the citizenship part of being a patient citizen. For me, and I think for everyone in healthcare, stepping back and being reflective about the role we want healthcare to serve in our society is beneficial. It's useful. Healthcare is a way of connecting us all at the most critical and sensitive aspects of our life, the moments in our life where we know how we relate to the broader society. And I think we're in the middle of a generational change of enormous volunteerism. Now, maybe it's the last one. The baby boomers have always felt the world revolved around their own navel. It's no different now as we reach later life. And we may be the last generation that has pensions, and we're able to volunteer at an early time. It's a population that is motivated for social change. We have our origins in feminism, our origins in the civil rights movement, our origins in accountability in government in a way that hasn't existed in previous generations to quite the same extent. And there's a kind of arrogance in that, but it's also a pool of resources and a pool of commitment that can enliven and can enrich the imagination of today's healthcare workers. But I would remind you that much of the motivation is about the kind of society we want to live in. We want to live in a society that has open access for a successful healthcare system that enables well-being. And making that transition from treatment to well-being is something this generation, I think, can absolutely revolutionize. It is about a kind of patriotism, a civic duty that we need to recognize and take advantage of. Well, I've worn a lot of different hats as a citizen patient, and this is just an example of some of the different kinds of roles, and Amy's introduction highlighted some of them. This is only a small bit of it. There are a few challenges that I'd like to just highlight, a few opportunities, and then I'd like to open this up to questions from you. First of all, the opportunity to be curious at every level, curious about what the patient experience it is. We don't have to wait for a formal patient engagement process. There's continuous learning. And the learning is by asking simple questions. And the questions could be from a porter. It could be from a surgeon. If we're looking at patient planning, what's the best you think you can be? To ask the patient about their expectations. What are their dreams? I hear a lot of pushback from clinicians. Well, patients have unrealistic expectations. I wonder why. Was there a discussion at the beginning? It's also the way to identify patient values and preferences. What's the best you think you can be in a rehabilitation program, in this intervention to prolong your life, in this possibility for a treatment plan? What can I do to improve your care today? What's the patient concern today in this moment? How can I participate? What's one thing that made a difference? What matters to patients? What's one thing that made a difference? It's what we're doing well. These are just the start of a conversation. As we build these relationships of trust, is this the answer? Well, I would say not really. I think that it's only the beginning of the first steps into realizing where the future of collaborative healthcare is going. And Angela has identified what I absolutely believe is the future, and that's patient-led care. Not patient partner, not informed decision-making, not shared decision-making, but patient-led care. I'd like to stop right now and just thank you. I know the schedule's moving on, and we've got lots of wonderful speakers to follow me. I'd love to hear your questions. Thanks very much.